Excellent. So very warm welcome to your PHEM1 oral OSCE, Adam. If you would be so kind as to start us off. So this first part of the assessment focuses on the case study that you wrote and submitted.
Yeah.
So please talk us through the evidence-based best practice for the clinical assessment and management of the patient in your 1,000-word critical discussion, providing a rationale for your answers. Time starts now.
Lovely. So I've got two key elements I'm going to talk about for clinical assessment and management of this patient. The first and simplest is probably going to be adrenaline. I say that's probably not actually that simple, but adrenaline in cardiac arrest has been fairly extensively studied. We recently had the Paramedic 2 trial, which found there was no evidence of increased survival to discharge, but there was an evidence of increased return of spontaneous circulation. There was also a systematic review in 2015 by Wampler et al., which found very similar results. It found that there was improved short-term outcomes, but limited change on survival to discharge. This raises some really interesting ethical questions as to, is this actually what patients want? I feel personally that ROSC is a bit of a surrogate endpoint. Nobody actually has their cardiac arrest and wants to get ROSC. They want to go home and see their family, and they want survival to discharge with a good neurological outcome. So it does raise an ethical question of should we be giving adrenaline to these patients? But at present and in the current, or the future, 2025 European Research Council guidance and soon to be the RCUK guidance, adrenaline is still in for non-shockable cardiac arrest rooms. One of the true questions talked about exemptions for non-GMC registered professionals. And I'm obviously aware that adrenaline is a JR Calc drug. However, there are exemptions for adrenaline which are quite interesting. Outside of JR Calc, there is an interesting exemption in the human medicines regulations for persons holding an advanced life support certificate from the Resource Council, which I think is very interesting. And in this particular case, it was actually useful for our ODPs to be able to administer the drug. I believe that's the entire reason it's in there. And obviously there's exemptions for everyone to use adrenaline for anaphylaxis. So the first part is adrenaline. Like I say, there's an ethical consideration there. And yeah, second part, we're talking about the team leadership of it. So cardiac arrest, part of the management is going to be quite clear team leadership. And as I referenced quite heavily, largely focused that case study on, we had changed to a split leadership model in that hospital before this arrest happened, which I don't say unfortunately, but did not unfortunately, it went well, which led to me running the cardiac arrest on a cardiac arrest team leader and a medical registrar running it as a medical team leader. So that is based on a really interesting conference presentation that I was lucky enough to be at from Ashley Liebig at SMAC, where she did the same in a hospital in Texas and found some interesting results. And then that was followed up by an interesting paper called CAN-LEAD, Cardiac Arrest Nurse Leadership. So CAN-LEAD is a really interesting paper, fairly recent, 2021. It's now mentioned in the ILCOR guidance when they did their structured review of evidence for the new guidance. And the way the paper worked, it was a simulation-based paper. There were 10 groups who would go through simulations in cardiac arrest, either with a single leader or with a split leadership model. After that, they were then asked to do the NASA Task Load Index score. So the NASA Task Load Index is a self-reported score of how difficult a task is. And the CAN-LEAD trial found some really interesting results that lower task loads were reported in the split leadership model between both members. So the theory from the study is that that would translate into better team leadership. There is some interesting critical analysis in this paper, I believe, because first it was simulation based. It was not based on actual patients, real patients, real cases. And we know people do perform differently in simulations. The stress is different in simulations as to what it can be in real practice. The NASA Task Load Index is a self-reported scoring score. So it's how you felt you performed, which is not necessarily how you actually did perform in that scenario. There was some good analysis in the paper where they talked about how a future paper should look retrospectively at how people actually did perform. And they could potentially use something like the team tool or anaesthetist non-technical skills as a tool for doing that. themselves, which are fairly interesting. As I read a paper that compared multiple scoring scores, watching someone to assess their non-technical skills, and found that the scoring scores did not line up fantastically well. So they may be quite subjective, actually. But and there were also some of the scoring scores, such as the team tool, again, themselves are only validated for simulation. Other interesting point is, due to the nature of the study, it was impossible to blind it. So the participants would have clearly known if they were in a split leadership or a single leadership model. And as the outcomes are self-reported, there is a reasonable chance that you could self-report lower task loads on a split leadership model if that's what you believed the researchers wanted to hear. So I think that might be all I've got.
Okay, thank you. So in relation to your case then, can you identify and evaluate or discuss any further advanced clinical assessments that might be beneficial to your patient, or the word, but so tell us a bit more about some of that side of your case.
So advanced clinical assessments for this patient would have been quite interesting. So they remained in cardiac arrest for a significant period of time. We got a short ROSC, which was used to deliver some fairly advanced interventions, a hysterectomy being the key one, with the aim of preventing blood loss, followed by a subsequent cardiac arrest. So advanced clinical assessments that were performed were ultrasound and arterial blood gases, which were done serially. We also had the obvious things like ECG and capnography on throughout. What I think the advanced clinical intervention, so I know this subsequently, so I don't know if I mentioned how the case ended, but I know this subsequently from the post-mortem. The patient had quite a large PE. So the advanced clinical assessment, which would have been optimal in this patient, would have probably been a CTPA. Obviously not achievable in cardiac arrest. The ultrasound didn't show any signs that would lead us to believe it was a PE. At the time of running it, we were under the belief it was either going to be a PE or an amniotic fluid embolism. And the advanced intervention we would have done for a PE would have been thrombolysis. However, the patient was hemorrhaging quite significantly. And at the time, and I still do believe that it was probably DIC. So, which fitted with the picture we believed at the time of amniotic fluid embolism. So administering a thrombolytic would obviously have been really unhelpful in that circumstance. So I think even if we were to perform an advanced clinical assessment, and if through some magic we could get them through a CTPA, if we found a PE, we would then be in a really interesting conundrum of whether we actually thrombolyze it, when I suspect we probably wouldn't have done in the circumstance either. We were a fairly small hospital on an island, so no option for anything interesting like thrombectomy. We actively discussed extracorporeal resuscitation as a team, and if it was possible to get a team out to come and do that, and the logistics behind that were not possible. The hospital that could provide that was not far. As the crow flies, it was probably 15 miles, but there is no system for moving them by air, and pulling that together mid-arrest is effectively impossible. So that was something we discussed, particularly as the patient was 37, so 37 just delivered, and reasonably fit and healthy. So we discussed extracorporeal resuscitation, but it wasn't an option that was available to us.
Fascinating case. Luke, do you have any other questions you'd like to ask Adam at this stage?
I don't. His last little statement just sort of summed up, really. I was going to ask what the etiology of the arrest was, and actually, based on that, could you have done anything differently? Obviously, that's with the luxury of hindsight, which you don't have at the time, right? But you've literally just answered that question entirely. So I don't. Thank you.
Perfect. In that case, let's move on to Q2. So part two. So this is all about understanding the nature of the systems, policies, governance, financing, etc., that are required to deliver PHEM. So and this focuses on the case study that was provided to you. So Drawing on an appropriate evidence base, please explain the optimal health service response to the patient in the case study, providing a rationale for your answers.
Okay, so when I thought about the answer I was going to give to this, the word that kept coming back to me was optimal. And actually, I think that's a really interesting word to use in the question. So the optimal health service response is something that we can't actually deliver. But the paper I looked at was 2016. It was impact brain apnea, a forgotten cause of cardiovascular collapse in trauma, which I'm fairly certain is like fairly common for us to have read, with all of the names that are famous from podcasts and whatnot. So like Gareth Davies, Gareth Greer, Simon Carley, John Hines, etc. So they described impact brain apnea, and they described it quite a lot in a motorsport context of superbike riders. They have a significant impact to their head, and that causes them to stop breathing temporarily. And the solution to that was to have a doctor appear on a superbike 15 seconds later, open the airway and potentially ventilate them. Now, I would suggest that that's probably the optimal health service response if we could do that. What we can actually do is we can get close to that using some of the guidance like System Saving Lives, which are in part of the resus guidance, where we teach bystanders to be able to do those, be able to do resuscitation type things. We know in the real world we are never going to get that close. So I did think about the word optimal, and actually we need an immediate responder. So there's an interesting paper based on the Boston Marathon bombing that created the phrase immediate responder. So EMS, police and fire being first responders, immediate responders being the people who are on scene. So actually we need those people to be appropriately trained to be able to do simple interventions like open an airway and potentially ventilate these people. I think that's the start of an optimal health service response. The next part obviously is going to be a call. Potentially future scanning, we're looking at e-call type systems in vehicles where the call is in automatic, but most likely it's going to be a 999 call taken by our call handlers. And while this is occurring, it's going to be given an AMPDS code and scanned by a critical care desk. Really interesting paper recently, 2023. 9 golden codes improving accuracy of PHEMs dispatch, which was based on the East of England. It was 4 years of data from 3 different services, EAAA, MAGPAS, and EHAT, with their 5 different teams, and looked into which AMPDS codes were being dispatched on the most and the likelihood of PHEMs intervention in them. Interestingly, of the 9 codes they found, 3 were RTCs, which probably suggests that these are exactly the right patients to be getting a level 3 team dispatched to. So the way the dispatch process is likely to work is probably on these patients, an immediate dispatch. Based on these codes, we know that these patients are likely to benefit. There's likely to be a PHEMs intervention performed. Obviously, numerous papers about that suggest there's equipoise about whether there is an actual benefit of PHEMs versus normal EMS turning up to a lot of patients. But for these ones, there's most likely to be an intervention. So these are the patients who are most likely to work for that. That paper was really interesting and did an incredible job of doing all of its own critical analysis in the discussion, which was fantastic. It talked about a reasonable potential for under triaging patients. So it was a retrospective paper looking at patients that were in the PHEMs-based system, and obviously based on that couldn't see the patients who did not get a PHEMs dispatch but potentially should have done. So potential for under triage there. And it also had an interesting thought about critical care paramedics on the critical care desk. So it found that there was only in stabbings and gunshots was there an actual change in PHEMs dispatch and in PHEMs interventions, and that was very small, versus just having a dispatcher on the desk. And one of the reasons that was surmised by the paper was that the critical care dispatchers work with critical care paramedics, and so will adopt the same model whether they're there or not. So didn't actually recommend getting rid of CCPs on the desk, which I thought was a really interesting thought on that. I think that might be all I've got.
Okay, thank you. So can you tell us a bit more about the governance and financial frameworks that inform PHEM services and why you think it's important to understand these?
Yeah, so home services are governed fairly tightly in quite some interesting ways. So our home services in East of England are dispatched by the ambulance service, but they are a separate clinical entity, so they do maintain their own CQC registration. They also, because they use an aeromedical platform, have to abide by the Civil Aviation Authority's rules. They are all charities, so they end up being regulated by the Charities Commission, often the fundraising regulator, and a lot of them also tend to run lotteries and things like that, so end up in some sort of gambling regulator as well. It's really important to understand these as there's quite a lot of moving parts, and one of the really key things that PHEM services need that normal ambulance services perhaps don't quite as much is public trust. Because they're charities, they do rely on direct public funding, whereas the ambulance services rely on general taxation, and you pay for the ambulance service regardless of whether you like what they're doing. PHEM services do need to maintain a reasonable level of trust. So an interesting example being Links and Knots Air Ambulance, who lost their ability to carry controlled drugs about 9 months ago to a reasonable level of press scrutiny over that. How did that happen? And while that's not directly related to fundraising, the press around actually that makes them look fairly incompetent. How did you achieve that? May end up affecting their funding, which affects their ability to actually deliver the service and deliver care. So yeah, some fairly interesting interactions there. Also, fairly interestingly, about why it's important to understand it is if we take a direct comparison to a US HEMS model, US HEMS is regulated by the Airline Deregulation Act in the US, which only allows the FAA to regulate them as they're an airline, and there's no clinical oversight. So actually that's led to some really interesting differences. You would expect being regulated only by the FAA, they would be safer, but that is clearly not the case. There is a significant more number of HEMS crashes. But it's also led to some interesting clinical outcomes and some clinical care where they aren't regulated in the clinical care they deliver or who they deliver it to. And an interesting analogy I've heard for US HEMS is because they're not regulated, asking American HEMS who needs a helicopter is like asking Starbucks who needs coffee. So yeah. So yeah, they do tend to fly patients who didn't necessarily require HEMS, but they end up with a significant payout for doing so. And there's no regulation apart from the FAA. So
interesting.
Yeah.
Okay, great. Thank you for that, Adam. Luke, is there any other points you want to pick up around HEMS systems, policies, governance, etc.?
No, thank you for asking.
Great. Okay, let's move on in that case, Adam, to part 3. So equipment governance and end of life care. So again, this focuses on the case study that was provided to you. So the scenario being that despite your best efforts, the patient arrests and you're unable to resuscitate them. You pronounce life extinct. So you're probably going to have needed some significant amounts of equipment in the resuscitation attempt for this particular patient. What are you now likely to need to unpack from the patient? What was it being used for, and what might the consequences be of unpacking it?
Cool. Like I say, absolutely agree. There's lots of kit that's going to be on this patient. One interesting bit of kit that there's a lot of evidence and research, well, not evidence to support, but there's a lot of research around would be potentially mechanical chest compression devices. So to the best of my knowledge, there's 3 still in use in the East of England. I don't know if EHAT still carry Autopulse, but there's Autopulse Lucas, and the corporal CPR arm is now in trial in East of England in Hertfordshire. So there's potentially up to 3 different mechanical chest compression devices. The evidence tends to treat them all fairly equally. There isn't really a great deal of evidence of benefit for the Lucas versus the corporal CPR arm, despite corporals trying quite heavily. So the real key evidence to support their use or govern their use will be the paramedic trial, the Link trial, and the CIRC trial. All fairly decent trials that reported fairly similar things. They are all a little bit old, 2014, 2015 types. They're about 10 years old now. But they have reported not really any evidence of benefit, but evidence of harm from these devices. So we know they are non-inferior, but they are definitely not superior to manual chest compressions. So for the East of England, our guidance is now been cleared. It's fairly simple now. For the deployment of mechanical chest compression devices, we use 3 E's, which is exhaustion, so you're too exhausted to continue using it. Environment, which I think potentially maybe where this comes into, like you're at the side of the road and it's potentially difficult to get people around the patient maybe, or maybe you're in a dual carriageway and you have all the space in the world and you don't need it. And egress, so we are moving the patient to somewhere. So perhaps, again, we're on the side of the road and we are moving the patient into an ambulance to perform resuscitation in the ambulance. Maybe that's when we use a mechanical chest compression device. But like I say, the evidence doesn't really support their use fantastically. It says they're they're not better than manual CPR. If we were doing manual CPR, we would end up using a device that has a significant evidence base that supports it, which would be a sensor on the center of the patient's chest. So depending on the defibrillator that's used, most likely ones are going to be the Corporal's C3T or the Zoll X series. Both of them have functions for QCPR, quality of CPR, and there's a reasonable amount of evidence that supports the use of quality of CPR for all cardiac arrest patients. The Zoll 1 is likely integrated into the pads commonly, depending on the configuration of the device. That's how my previous trusted it, and that's personally the one I quite like. But the Corporal's one is definitely separate, and the Zoll one can be separate. Removing those might be fairly interesting, as this patient has died from an RTC, and they are at the roadside. And I feel like I'm probably leaning into the next question a little bit, but they are they are on the roadside, and there's likely to be quite significant investigation into it, and we do have to worry about forensic awareness, preservation of evidence, things like that. So looking into this, I read the College of Policing's authorized professional practice document on what to do as a road collision investigator, which was actually surprisingly interesting, and split deaths at RTCs into 5 categories, which were kind of like GCSE grades, from A plus to A, B, C, D, and talked about who needs to investigate them. At A plus, it was a nationally recognised serious investigations officer. At D, it was this patient has likely had a medical arrest and then has crashed their car. And it can be a more local team, but they're likely to need a forensic collision investigation team to attend. And there is a reasonable medico-legal aspect about removing kit for the investigation.
Great. Any other equipment? Thanks. That was a lovely little segue into the legal aspects surrounding death. But if we can sort of go back to equipment, that would be great.
So other equipment that's likely to be used, end-tidal CO2, likely to have been used in this patient. I say likely, mandatory to be used in this patient, but hopefully been used. Resus Council guidance, particularly the new 2025 guidance, makes this absolutely mandatory. Interestingly, there's also a coroner's ruling to prevent future deaths, I think it's Rule 43, which says that any pre-hospital advanced airway management must have end-tidal CO2 attached. That is something that we take fairly seriously within East, and any cardiac arrest that has an advanced airway and does not have end-tidal CO2 documented is sent out as an email each month to go and be investigated locally to work out why that happened. The most common one is I forgot to write the end-tidal CO2 number down, which is good, rather than I forgot to put the end-tidal CO2 on. But end-tidal CO2 is almost certainly going to be attached to this patient through their advanced airway, which is again another piece of kit we're likely to have to remove, an advanced airway, so an iGel or an ET tube. Likely to be an iGel for most patients in cardiac arrest. With a PHEM team, we may well have intubation, which is good. We probably still reasonably believe that to be the gold standard of airway management, but we know from Airways 2 and multiple other trials that there are problems with airway management pre-hospitally. One interesting thing being the Difficult Airway Society says that any pre-hospital airway is a difficult airway. They define that just being outside of hospital as a difficult airway. And slightly older paper, but NAP4 from 2011, I believe, found that any patients, which was an in-hospital paper, it was an in-hospital audit, but found that any patients who having their airway managed outside of a theatre environment had a significantly increased risk of complication. So yeah, potentially an ET tube or an IJAM.
Great, thank you. So we've got just over 5 minutes left, so it seems like a good time to move to question 2 of this section. So notwithstanding what you'd said already about starting to talk about in terms of forensic awareness, how would you approach the legal, ethical and cultural aspects of this case, and why?
Yeah, so like I briefly went into, a really interesting bit of authorised professional practice from the College of Policing. One of the other interesting things it mentions is that the family may want to attend, which I found a really interesting phrase, because I've always considered that in resuscitation. A normal cardiac arrest, there's some really good evidence for familial involvement in cardiac arrest. It's recommended in the guidance, and there's some really good supporting literature that having the family present during cardiac arrest leads to lower instances of psychological problems in them. They get to see a large multidisciplinary team that does everything that can be done, and what they see is often a lot better than what they imagine happened. Some interesting evidence that you shouldn't force people to do that. You should give it to them as an offer, and if they take that offer, then they're likely to have some psychological benefit. I do know that we normally do that for adults, and we do that for parents of children. Interestingly, Great Ormond Street do that for siblings as well. They allow siblings to be present during resuscitation, which I think is a little bit mind-blowing, and is probably something that's really quite clever and really quite sensible at Great Ormond Street only. Not something that could be reasonably supported in any other hospital, or certainly not pre-hospital. But interesting that they have found some slight evidence of benefit for siblings being present, and that giving them some sort of closure. They get to see everything they can. So yeah, it mentions how the family may want to attend, and there's some interesting technicalities as to how we do that on the roadside, which I can't say I have an answer for, in honesty. I think that would be a policing problem rather than our problem as to how we actually get them there. Interestingly, it did talk about how local highways often have policies on allowing people to lay flowers, and that's actually a governed policy type decision, but talked about how that's obviously never appropriate on a motorway or a dual carriageway or fast road. So yeah, the cultural, ethical and legal aspects, most likely family attendance. Another one that might be interesting, so this patient has died, and different cultures may want to bury them in a different speed. So, and a recent RTC in Portugal was Diego Jota, the footballer, and his funeral was, I believe, 3 days later, which is an astounding speed for someone who's died in an RTC. And I'm not convinced we could ever achieve that in the UK, but that would be standard in a Portuguese culture, that they would like the burial to happen in 2 to 3 days. I'm not sure that we would be able to adequately investigate it, perform a post-mortem, and have the body ready to do that if we wanted to do so for potentially a Portuguese or similar family who wanted that to happen. So it's an interesting cultural aspect that I hadn't considered. On a pure tangent, because while I think of something else to say, my wife is Portuguese, and one of her colleagues told her that they had a funeral in 2 weeks' time, and they needed some time off work, and she couldn't quite understand. She thought, well, how have you planned that they're going to die? Because she just always normal that you bury someone 2 days after. How do you have a funeral in 2 weeks' time?
Right, I see.
Yeah.
Interesting. Right, well, we've got about 1.5 minutes left in terms of time. Luke, are there any other questions that you want to pick up at this stage?
I have no questions, thank you.
So, as we've got a minute, what, Adam, do you think, what circumstances make it challenging to work within legal and ethical frameworks in PHEM, do you think?
Interesting. Circumstances make it difficult. So, stress. There's a lot of human factors stuff that occurs within PHEM. We work in a difficult, challenging pre-hospital environment, which is what basically every study says at the beginning, isn't it? Or the excuse for not being able to do effective research is a challenging pre-hospital environment. But to a degree, that is true. We work in potentially a nice calm environment, potentially a high pressured environment in a dangerous, difficult, austere environment. And the additional stress of that is likely to lead to poorer decision making, like potentially leading to poorer decision making. If you're working in a high pressure stress environment, there is a potential for making poorer decisions. So it's probably a good argument for making sure that we effectively simulate things. And like I said, I haven't said it in this one, there's many ways that we talk about simulation. Previously, stress inoculation was a thing. Now we're probably more talking about simulate to flow. But those sort of things, so that people understand how they respond, so they can effectively make better decisions, or teams can see when each other is stressed, would potentially allow better decisions and make it easier to continue to work in those frameworks.
Great, thank you. And that is 30 minutes. So I'm going to have to stop you there, I'm afraid. Adam, thank you so much for all of your responses. I'm going to stop the recording there.